My name is Doug Keeper. I've been involved in clinical research for nuclear medicine breast applications for about the last 15 years. My primary works have been in single gamma, but I've also worked on PET systems with the Department of Energy in the United States and Duke and a few other universities. So this talk is going to concentrate primarily on the single gamma method, often referred to as breast-specific gamma imaging or molecular breast imaging. And I think everyone is trying to coin a new phrase, it seems every day of the week, but it's technetium-based generally. Breast imaging with nuclear medicine tracers, there have been quite a few radioisotopes that have been used. Sestamibi, tetraphosphate thallium-201, these are very common cardiac imaging modalities. And then there's several others that are either being investigated or have already been developed. Technetium, furofosmin, the MIBI, and several other drugs. But the vast majority of the available clinical data to date has been really focused on MIBI. Whether that's a good thing or a bad thing, I'm not really sure. The one thing that's very interesting about Sestamibi is and we'll go over some of the characteristics, but the one thing is that clinically, it's really very useful. I think at the end of the day, that's what we're finding, is that it's a clinically useful tracer. It's a 140 kV gamma emitter, of course, with a 6-hour physical half-life. And this is actually new data that we're publishing now. And this is something that's important to keep in mind, is that we're finding that it only has about 134-minute half-life in the breast tissue. And so this is a little faster of a washout than I think maybe people had previously suspected. So it points to the fact that maybe we need to do imaging relatively quickly after injection. It's not a rush, but you certainly don't want patients waiting in the lobby for 45 minutes after they're injected. One of the strengths to this particular technique is that the patients aren't required to fast. They're not required to have preparations. And then again, the injections can be conducted essentially immediately after injection. As it was already presented today, it's a lipophilic molecule. Accumulation is roughly proportional to blood flow, desmoplastic activity, and cellular proliferation. It is a substrate for the P-glycoprotein receptor. However, a lot of the data that particularly came out of Italy in the very early days of the MIBI research in breast tumors is indicating that the washout times, even for PGP-positive tumors, is relatively slow. So about 90 minutes post-injection is about the half-life of PGP. So for overall in the breast tissue, it's about 134-minute half-life. But for PGP-positive tumors, it's about a 90-minute half-life. So we really want to do this in imaging relatively close to the injection time. The clinical delivery is very simple. It's a syringe IV puncture in the upper limb. Typically, we try to concentrate on the contralateral limb whenever possible. And the primary reason for this is that if the technologist extravasates that dose into the subcutaneous tissue, that subcutaneous tissue is drained by the lymphatics. And what you can see in that case is you can see enhancement in the nodes, in the axillary nodes, and whether that enhancement is because of tumor or because of extravasation of dose, you're not entirely sure. So whenever possible, we typically try to inject into the opposite arm. There have been a variety of techniques to try to avoid this, people injecting in the feet and several other things. But having had to do the foot injection myself, it's painful for patients, and it's not a very easy technique to perform. So we find that just a good, clean injection technique in the opposite limb is typically sufficient. As several of the presenters today have discussed, these other modalities of mammography and ultrasound and MRI, and specifically mammography and ultrasound, are really concentrated on the architecture of the breast. And we're looking for things that appear to be out of place and things that appear to be malignant in the architecture of the breast to indicate the presence of disease. The challenge with doing this are two challenges, basically. The first challenge is If the breast is very complex, if there's a lot of architectural things in the breast tissue, that makes the interpretation of mammography and ultrasound difficult. The second condition is that we find that you're waiting for an architectural change, an anatomic change in the breast tissue that indicates the presence of the disease, rather than looking for the fundamental changes of the disease to indicate its presence. So this BSGI or MBI, or this technetium-based technique, we're essentially looking at mitochondrial binding pharmaceutical, which gives us a relative idea of what the physiology of the breast tissue is, and we're looking at the tumors based on an enhanced metabolic rate. And this isn't always true, but it's a general curve. Generally speaking, normal cells have a little bit of uptake of Sestamibi, and then you see inflammatory responses can have some elevated uptake, as can atypia, and then malignancies have kind of the highest uptake of all. And this is certainly true for the more aggressive tumors. Their enhancements are very, very bright, but it's not altogether an entirely linear curve, and I think that's true for, we see it in the MRI spectroscopies, we see it in all of these techniques, and so we really have to employ all of these tools in order to give us the best picture of what's happening inside of the breast tissue. The key to these improvements, and this is the same thing, by the way, with the PEM technique, is to move away from these whole body imagers that have a relatively gross resolution because they're engineered to detect fairly large things in the entirety of the breast, or in the entirety of the body. These specialized detectors, which put us in very close geometry with the breast tissue, greatly enhance our spatial resolution for the study. So it's not just an improvement of the detector's spatial resolution, it's the decrease of the distance from the target to the detector that's enhancing your spatial resolutions as well. That's the first major improvement. The second major improvement is that now we can image the breast in the same projections as we do the mammogram. So now we have an X-ray image, which gives us an anatomical reference point for the breast tissue, and we have the BSGI MBI test, which is done in the same projections, and now we can get a correlative idea of what's going on in the side of the breast. I think in the initial days of Sestamibi breast imaging, there was a lot of talk about what it could do and what it couldn't do, and who were appropriate patients and who weren't. And now we have a fairly large bulk of data behind us, and I'll show some of the data in a moment. But I think as I look through the data and I really start to look for what are the, we have all these indications, and what are the key values if we were trying to break this down into what kinds of patients really end up benefiting from this test. I think those patients fall into four categories. I think the first are diagnostic patients who have an unresolved diagnostic concern after mammography and ultrasound. And so these are patients who've presented, they don't have entirely normal tissue, they don't have an obvious malignancy, but they have some kind of confounding issues that are difficult to manage in a clinical perspective. And there's a variety of these kinds of examples, patients who have a palpable mass that's negative on mammography and ultrasound, and there's a whole variety of these kinds of diagnostic questionable things. And those patients without question benefit. And in the presentation I'm going to give after the break, I'll show you some of the data from that specifically. Patients with a current diagnosis, and this is really an area where you have a lot of overlapping technologies. You have PEM and you have MRI, and a lot of technologies are looking at this. And the basic principle is that we understand from clinical studies that mammography doesn't detect necessarily all of the disease that's present when it's positive, and that there's certainly some benefit to doing some of these other imaging technologies to identify what the extent of that disease presence is. The third kind of patients are patients who are undergoing chemotherapy to monitor the tumor response. And this is actually a very effective technique. I think it's maybe a little not as quick as the MRI technique in its response curves, although I don't know of anybody who's tried to image 24 hours after injection, but it certainly has been shown to be effective in the tumor response. And then in patients who have a history of breast carcinoma, who now have had surgeries and radiation therapies and things that can dramatically influence the appearance of their breast tissue clinically on mammography and on ultrasound, but it can be difficult to differentiate those changes from being new malignancies from being scar tissues or other things. And so it can be a very useful technology for those groups as well. So again, I think if we're looking at how these things are implemented, we're talking about patients who have some type of a concern that has resulted typically in a diagnostic mammogram. I do believe that that's the best entry point still for all the given data. And from the diagnostic mammogram, the patients may go to an ultrasound, a clinical examination, or a BSGI. And given the response that you get for any one of these techniques, you may end up doing another one, because ultimately there's a fundamental question here. And the fundamental question is, do we need to take this thing to the next stage? Does it need to be biopsied? Do we need to look at treatment? Kind of if you've exhausted all of these things is typically where the centers who are practicing molecular breast imaging, that's when we see them maybe employ breast MRI, is after they've exhausted this less complex technology. If the patients don't need a biopsy, then of course they return to a follow-up. If they do require a biopsy, then the next question is there a malignancy? If not, they return to follow-up. And if there is a malignancy, now you're moving out of this primary diagnosis phase and more into a preoperative planning. And again, like I said before, this is where we more commonly see MRI and positrons and other things being employed as well. So these are my personal rules for interpreting BSGI, but I think that they're founded on thousands and thousands of patients of data, cross-correlating several studies. The first is that, and I think what the speaker just before me mentioned it, interpretation should be conducted with all the available imaging information provided to the clinician. The more photographs, if you want to think of it like that, the more photographs, the more pieces of information that we have about these tumors or about these disorders, the better idea we get as to whether or not they're going to be malignant, they're going to be highly aggressive malignancies, that type of thing. Second is that it should not be used to obviate the need of biopsy in patients with a positive mammogram, ultrasound, or MRI. So that's a very specific statement. I mentioned before that it's very useful in these patients who have questionable findings on mammography and ultrasound. So these are patients where we haven't made the decision that we think there's something malignant, but if you've decided that based on a mammogram or an ultrasound that you think there's a malignancy, these technologies, and this is true for any technology, no technology should be used to obviate the need for biopsy based on a positive finding from another study. And so what does that mean? That means that, what we're really looking at is we're looking at patients who have, clinical signs or symptoms that are either they don't have any clinical signs or symptoms, or they have a positive clinical sign or symptom, bloody nipple discharge, palpable mass, this type of thing, or questionable clinical symptoms. And mammography is either questionable or negative, and ultrasound is either questionable or negative. And in these cases, this is where I think these technologies are really useful. And then you conduct biopsy if the molecular breast imaging is positive. Of course, if patients are entirely negative, they don't need anything else. Patients, if any of these other modalities are positive, then you don't do the molecular imaging techniques, you go straight to biopsy. And so that's kind of a distinct, by the way, this is a chart only for the index lesion. This isn't necessarily talking about utilizing these technologies for additional disease. This is the decision-making process for the index lesion. So some general procedural notes. We're finding that, roughly 10 millicuries is sufficient. The US FDA drug data sheet says 20 to 30 millicuries. That recommendation was built on the photon sensitivity of whole body breast imagers, or whole body imaging systems. And it looks like with the improved photon sensitivity of these newer detectors, that can be reduced. Imaging can begin about 3 minutes after injection. This was a group of patients that we looked at Hampton University, a series of 40 patients where we did dynamic flow acquisitions to determine the curve uptake times. Can begin about 3 minutes after injection and be conducted for about 90 minutes post-injection. Compression is very light. It's much lighter than they apply in mammography. It's just really enough to mobilize the breast to keep it from moving. Each image is about 5 to 10 minutes, and that becomes somewhat dependent on how comfortability of the physician to read nuclear medicine and their familiarity with the procedure. We find that somebody with more and more experience uses shorter and shorter acquisition times or lower doses because they become more comfortable with the way the images appear. And this is a very strong recommendation of a 4-view bilateral examination. And there's 2 reasons for this recommendation. The first is that we have found an appreciable number of unsuspected contralateral malignancies in patients who are undergoing this imaging. And the second reason is that patients can have somewhat complex appearance in the breast pattern, and having the contralateral breast as a reference point can sometimes help with this heterogeneous uptake. Now, what can this technology really do? For the breast radiologist, it can help find malignancies that are missed by mammography and ultrasound. It can provide a high negative predictive value to help alleviate biopsies for these questionable findings, again, questionable, not positive, in mammography and ultrasound. And for the breast surgeon, it can help improve surgical planning, provide a better understanding of the position of the tumor, and then to help them improve their planning, and then also monitor the tumor response to neoadjuvant chemotherapy. So this is I didn't realize this case was still in here. This is obviously one of our older cases. This is still in film screen mammography, but the patient has an obvious anterior retraction of the breast tissue. You can see the blunting here. There's a skin adhering lesion that's clinically palpable. She has kind of this extending density on the mammogram, and then some things in the contralateral breast that look a little bit weird. And on the molecular breast imaging technique, you can see very easily that there's 2 lesions that can be excised simultaneously. It is, like all of these technologies, not entirely foolproof. The positive predictive value of this technology is about 70%, 60 to 70%, which I'll remind you is about twice that of mammography and ultrasound combined. But there are some false positives, particularly some precancerous conditions like lobular carcinoma in situ and atypical ductal hyperplasias and atypical lobular hyperplasias. Some benign conditions can also be false positive at times, mastitis, fat necrosis, and sometimes fibroadenomas. But the fibroadenoma diagnosis, remember, is a very broad descriptor for this fairly complex group of tumors that can be very, very high cellular density or very fibrous, and so only some of those are positive on the technique. And then at times sclerosing adenosis as well. This is a patient with a positive family history, a mother and a sister who were both diagnosed with breast cancer before the age of 50. She had a very radiodense mammogram, and she really persisted at the clinic and demanded to have something else done, even though there was really no specific indication for her other than her family history. But this case is interesting, primarily because what we ended up finding was this very small focal abnormality in the left breast. And under an ultrasonic examination, and this is key, if you had to do a whole breast ultrasound to look for this 3 millimeter mass, it would have never been found. But utilizing the molecular breast imaging technique as a means to determine where you're looking and what size of an object you're looking for, they were able to find this under a second look focused ultrasound and biopsy it, and it's a ductal carcinoma. This is a patient who has an obvious spiculated mass. Not much question about that, but she has some other appearances in her breast tissue bilaterally. There's the known mass on the molecular breast imaging. And then what we see here are 2 additional foci contralateral to that. And with this, the patient initially she refused an MRI. That was the reason they did the molecular breast imaging technique. And then she did this, and they convinced her to be sedated and undergo the MRI. But the results of this case are very interesting. So the 3 lesions that are circled are the 3 that were positive by nuclear medicine technique. And on MRI, there's 3 additional lesions. And this poor woman ended up having ultrasound-guided biopsies of all 6 of these spots. And here are the results. There's the known malignancy. So this was done before the molecular breast imaging technique. This is a benign lesion, and a benign lesion, all positive by MRI and negative on nuclear medicine. This is a contralateral infiltrating carcinoma, positive on both the MRI and on the nuclear medicine technique. And here's a contralateral benign lesion, positive on both the nuclear medicine and the MRI technique. So of the 4 malignancies that were benign, only one of them was positive on the nuclear medicine technique, whereas all 4 of them were positive on the MRI. This is, I'm only going to cover just a few pieces of data in this presentation. I'll continue some more after the break. But this is a prospective trial done in Korea of 662 patients with 665 breast lesions. You can see there were 192 malignant and 473 benign, which is pretty typical for breast practice. The overall specificity in this patient group was 87.9%. And this is, I think, this tells the story better than I think anything else I've read, is that you can see that the sensitivity of the nuclear medicine technique was the same throughout overall in the fatty breast and in the dense breast. It was all about 95%. Whereas mammography overall was 75%. In the fatty breast, it was slightly higher, and in the dense breast, it was lower. And so that's really the power of the technique, is that it provides this kind of equal sensitivity. This is a meta-analysis, and we're still working on some publications. There's actually someone who beat us to the punch. It was a great paper, by the way, out of China, published, I think, just last December in an American journal, and they did a great job of a meta-analysis. But this is our meta-analysis of about 5,008 patients in a conglomeration of about 30 papers and presentations. Overall sensitivity was about 92%. The overall specificity is 77%, and the reason that this is starred is that the specificity, of course, is highly dependent on the patient population selected. So if we look at patients with known malignancies, the specificity is higher. It's into the 85 percentile. If we look at patients with a questionable mammogram and a questionable ultrasound, of course, that group of patients has a low incidence of malignancy, but a high incidence of other disorders. And so the specificity will wane a bit. It'll go down into the 65, 70 percentile. And the overall negative predictive value, that's maybe the most important thing, is the overall negative predictive value is 97%. This was a specific study, but it did an interesting thing. It looked at the various subtypes of lesions. Overall, they found that the sensitivity was 96% in this case. Invasive malignancies was 97%. Sub-centimeter lesions was 89%, no surprise there. It goes down a little bit with the smaller tumor size. And then in DCIS, it was a 94% sensitivity. And that, thank you very much.